Greetings, everyone. Welcome. Let's get settled and we'll get started. My name is Bill Rapisi. I'm the Executive Director of the Lymphatic Research Foundation, and I'd like to welcome all of you to what is actually our first live stream symposium. We've had symposiums certainly in the past, but they always have been in communities that were accessed by those people that were local. In this case, there's the opportunity to access people internationally, and afterwards this live stream will live on our website as an archive so people can visit it later on. Why is that important? Well, in part it's important. Today happens to be Lymphedema Awareness Day. I thought perhaps a show like The View, which appeals very much to women, would feature that fact on their program. So I looked at what was going on in their program today. Well, we probably almost got there, but we were beat out by Frozen Food Day. It happened to be National Frozen Food Day, so they did have a lengthy program on that. So the 10 million people in this country that have lymphedema didn't quite get a voice on The View today. But I think in part that's why we're here, because people with lymphedema are not getting a voice. And those 10 million people too often don't know that lymphedema even is a possibility for them once they have received treatment, or those that have secondary lymphedema. They are too often told by their physicians afterwards that they should be happy that their lives were saved, if in fact it was cancer that they had previously. And too many people sit in silence and don't communicate to others what it is that they actually have. Part of what happens with what's going on here today is, I think in large part, if you want people to be very vocal about something they have not been vocal about, you need to give them reason to hope and speak about it. And today we are going to hear about something that very much gives people with lymphedema hope. Before we get into that, just a couple of notes. I would like to say, mark your calendars. The symposium series, there will be another symposium on May 22nd, where Dr. David Chang, a professor of Department of Plastic Surgery at the University of Texas MD Anderson Cancer Center, will talk about overview of surgical treatment for lymphedema. And in July, Dr. Babak Marmara will speak on cellular mechanisms of lymphedema. Dr. Marmara is at Weill Medical College of Cornell University and is also a surgeon. Two reminders: you do have the opportunity to ask questions. We did ask that you sign a waiver beforehand so that we have the right for your voice to be on our live stream. We are not going to be doing any videotaping of the audience itself, so you will not be seen in that regard. If for any reason you do not want your voice heard, you can always write your question down, hand it to Phyllis Reed here, and she will read the question at the end of the lecture today. With that, I would like to introduce today's speaker, Dr. Joseph Dayan. He is the attending plastic surgeon and director of plastic surgery research here at Beth Israel Medical Center. And Beth Israel is also our host today. We are in New York City, where it seems every time we try and do a live stream, there's a storm. The last time we had this planned, we were going to be out at North Shore. Long Island Jewish Hospital is on the island, and Hurricane Sandy came along, and we finally ended up having to cancel it because they had to turn the room into an emergency ward. This time we have another storm, but even still we have a great audience here, and we have up to another 100 people that are watching this from around the country as well through live stream at this point. Dr. Dayan is a board-certified plastic surgeon specializing in microsurgical cancer reconstruction and lymphatic surgery. His work on vascularized lymph node transfer has been presented internationally, and he is a founder of the American Society for Lymphatic Surgery. Dr. Dayan also performed the first lymph node transfer in the tri-state area and in Israel with his colleague, Dr. Mark Smith, who is also here today. Dr. Dayan will be speaking on vascularized lymph node transfer. And without further ado, I introduce you to Dr. Joseph Dayan.
thank you so much, Bill, for that wonderful introduction. And it's truly an honor to be here. And as you said, I'm here with my colleague, Dr. Mark Smith, which has really been a co-collaborator and partner in all of this. So everything that you see that I'm presenting is really a true partnership. As you pointed out, lymphedema is just under-recognized, and most of the public who's never been directly affected by it has never heard about it. As you know, most of what we do is microsurgical cancer reconstruction. So our experience with lymphedema really started with our patients, often undergoing breast cancer treatment or treatment of other types of cancers that resulted in permanent swelling. And this is really a big problem. It's a common problem, and it's very difficult for a doctor to see a patient suffer and really offer no hope or no help for them. And my background is in microsurgery, which is basically a technique where we can sew tiny blood vessels together about 1 millimeter or 2 in diameter to transplant tissue from one part of your body to another. And we do that for breast reconstruction and all kinds of reconstruction, but we can do that for lymph nodes as well. Before we jump into lymph node transfer, I just wanted to take a step back and make sure, at least basically, we're on the same page about the lymphatic system and what it does. It's difficult to really understand lymph node transfer at all without understanding the underlying problem. And there are really two main functions of the lymphatic system. One is fluid balance. About 2/3 to 3/4 of the fluid that is pumped to your skin and extremities from your heart returns back to your heart through the veins. But there's a whole bunch of fluid that's left over, and that's left for the lymphatic system to bring back to your circulation and clear. And when that's not functioning properly, you get swelling. The lymphatic system also has a tremendous immunologic function. It's where all the T cells, immune cells, are really stored and fight infection, and also have a role in monitoring and killing cancer cells. So when it's not functioning, you can be prone to infections. A lymphedema is basically swelling caused by an impaired lymphatic system, and it's often permanent. And the natural history is that it doesn't usually get better. If anything, it stays the same or gets worse, and that's really the biggest fear and challenge we face. But it also has other consequences, such as recurrent infection. Cellulitis, which is just a skin infection, can be very severe in patients with a compromised lymphatic system, sometimes requiring IV antibiotics. And in rare cases of long-standing lymphedema, patients who have growth on the skin that can look purplish or violaceous, a new growth, can sometimes evolve into lymphangiosarcoma, cancer. Diagnosis of lymphedema is often delayed in our society because most people in the medical community, I think Stanley Roxon did took a poll in a study and said basically more than half of us only receive less than an hour of review of the lymphatic system in medical school, and it's true, it's generally neglected. So oftentimes it comes down to a history and physical. You have a swollen extremity that's not going away. Maybe they'll do an ultrasound and look at the venous circulation, and if that's fine, and you don't have protein wasting syndromes or other causes for swelling, then you have lymphedema. You can confirm it with a lymphoscintigraphy, but there are other ways to look at lymphedema, and there are ways to look at the impedance, which is the resistance of an electrical current across the arm, which reflects the fluid content. There's the SPY system, which I'll show you, and now MR lymphangiography. And a lymphoscintigram, I just want to, actually my pointer's not working, but if you can see to your right side in the upper right-hand box, that all of that black dye, that's dye that was injected in the foot that can't get out of the leg. It should normally be clear and go straight up to the lymph nodes, but it doesn't. It just sits down in the leg, and that's lymphedema. Treatment for lymphedema, By the way, I have no disclosures. I don't own stock. I'm not a paid consultant for any technology or anything that I'm discussing. Treatment for lymphedema, really the mainstay is decongestant physiotherapy and lifelong compression. And this surgery is not a replacement for physical therapy. In some of our patients, they have been able to stop daily compression, but we are not in any way advocating this as a replacement for anything else. This really is an adjunct, and patients have seen, most of our patients have seen benefit. Some patients have stopped compression, and some patients have not seen benefit. So this is a piece of the puzzle for lymphedema. It is not an overall cure. However, as things go, this is really laborious, and it recurs once compression goes away. The impact cannot be understated. The time burden for somebody who's really doing religious compression is often hours a day. In terms of like having a requirement for hemodialysis, it really can interrupt some of our patients' lifestyle. In addition to the discomfort and limited range of motion that can occur, it interrupts certain activities. Some patients have difficulty with air travel, warm weather, doing the activities that may expose them to bug bites and scratches. And a lot of our patients fear that this is just permanent and oftentimes worse than the breast cancer treatment in those patients that have lymphedema related from oncologic means. What causes lymphedema is still partly a mystery, and the evolution of surgery, of medicine, medical treatments, and physiotherapy go hand in hand with the evolution of understanding this problem. It's not just simply a blockage. In cases of primary lymphedema, we know that there's some inherent abnormality of the lymphatic system. It could be not a normal number of lymph nodes. It could be the lymphatics are not pumping properly. But in secondary lymphedema, where lymph nodes were removed, if this was just a blockage, then the entire arm would swell or the entire leg would swell, and that would happen immediately, and it would never go away. But we know that's not the case. Some patients don't develop lymphedema for many, many years. Some patients have their hands spared, and it's just their forearm. Some patients have certain parts of their body that are worse than others. It doesn't really always make sense. A lot of the great basic science research that's been done across the country and the world has shown us that this is really seems to be a proliferative disorder. The fluid that initially builds up over time naturally gets replaced by fat. There's actually production of fat, and if you look on scans, which we work everybody up with, we see a lot of fat. So that's interesting. It's not just a blockage, and not all lymphedema is the same. The way we classify lymphedema is really mild, moderate, and severe. It's whether your extremity gets better with elevation or not, whether there's pitting or not pitting, whether there are skin changes. But that's just skin deep. It really doesn't tell us what's really going on. Why do some patients develop lymphedema immediately and other patients it takes years to develop? Why do some patients have recurrent intractable infections and other patients have never had an episode of any infection in their life and have had lymphedema for 25 years? Are they really all clumped into the same just because they have the same degree of swelling? It's more sophisticated than this. And we have imaging technology that's much better these days. Nobody would stage a cancer. Nobody would think of staging a cancer based on history and physical. We do CAT scans. We have PET scans. We base cancer staging on new technology and imaging. And we should probably be doing the same for lymphedema and looking closely and really diagnosing and classifying. I'm going to talk about the problem with surgery and lymphedema because most of my training had nothing to do with lymphedema in residency. I was not exposed. It was really in Taiwan under the mentorship of Dr. Mingwei Chen, who's practiced lymph node transfer, which I originally learned from. This is something new, but surgery for lymphedema has been around for a while. There's been lymphovenous bypass, there's been radical resection, there's been liposuction, and there's been lymph node transfer. But why is this not widely practiced? Is it all baloney? Is it dangerous? I mean, there's a lot of discussion around this point, and I think when I go to lymphedema surgical lymphedema conferences, there are a lot of different things being practiced. There are a lot of different approaches, and there's no consensus on the role for surgery or what type of surgery, when, in which patient. And that's partly because lymphedema remains a bit of a mystery, and it's difficult to judge an outcome. So how do we know if the surgery worked? We can show before and after photos, we can take measurements, but we all know that physical therapy is really maybe in the background, and maybe it's the physical therapy, maybe the patient was wrapping much better after surgery than they did before surgery. Maybe when you took the picture before surgery, it was their worst day. So all of us, not just patients, but surgeons that are entering this field have a natural degree of skepticism when it comes to surgery. And in summary, there's just general confusion and skepticism because there's a lack of good prospective data in the literature and difficulty in measuring outcomes. Talking a bit about a general surgical approach to lymphedema can be divided into two categories. One is debulking surgery, which really is not treating the underlying problem, but trying to give the patient some degree of added comfort by removing that extra weight or that extra bulk. And this comes down to liposuction or radical skin resections, which have been around for quite a long time. Not everybody, however, is a candidate for this, and it doesn't really treat the problem. You do have to wear compression. Once you remove compression, the lymphedema just comes back. And in somebody with mild lymphedema, just because a patient doesn't have a big arm, but they do feel their arm is heavier, and they do have to wear compression every day, even though if you took a photo and their arm doesn't seem big at all, it doesn't mean they're not suffering. We've seen patients that it has really interrupted their life, even though you may look at a photo and say, wow, she looks fine. They're compressing and they're prone to infection and they're wrapping and wrapping and wrapping, and it's really interrupted their life. They're really not candidates for liposuction. Then there are physiologic approaches. Physiologic approaches aim at trying to treat the underlying cause, trying to bypass the obstruction, trying to improve the lymphedema at its cause. And these really come down to lymphovenous bypass, which is basically cutting a lymphatic and sewing it into a vein next door and trying to bypass the obstruction. It's lymphatic vessels are very tiny. They're often a third to half a millimeter in diameter. Technically challenging. And we also see patients that their lymphatics are so far gone you can't even find lymphatic vessels to connect. But it has been shown to be effective in certain patients. Again, these are just pieces to the puzzle, and it's not right for everybody. The other option is lymph node transfer. Lymph node transfer, which I'll discuss in more detail, is basically transplanting lymph nodes from one part of your body with the blood supply into the part of the body that needs them. And those lymph nodes stimulate lymphatic growth into the lymph node itself and then shunt that fluid away and out the extremity. But the goal for physiologic procedures is maybe in some patients to eliminate or minimize the risk of infection, which we've seen, hopefully to reduce the size of the limb, maybe in some patients reduce or sometimes eliminate the need for daily compression, or at minimum avoid progression of disease. So what is vascularized lymph node transfer exactly? It is a microsurgical procedure, meaning we do this under a microscope. What you're looking at, and I want to just let you know there are some, I tried to limit the graphic pictures, but it's hard to describe this procedure without showing you some, so please turn away if I offend you. This is basically, these are lymph nodes with some perinodal fat, just fat around the lymph nodes in the groin, and the instrument is pointing to blood vessels. Those blood vessels and artery and veins supply circulation to the lymph node. And in order for those lymph nodes to stay alive, it needs a circulation. So we actually cut those lymph nodes, and then we transplant them to the part of the body that needs them, and we sew them under a microscope to blood vessels in that region. Physical therapy is really a critical piece of this puzzle. If it really demands somebody who's willing to comply with physiotherapy before and after lymph node transfer. And we're also looking at adjuvant medical therapies. The entire inflammatory cascade that's being studied. Particularly in patients, IL-4 blockade, IL-10 blockade, anti-inflammatories. We're really looking at is maybe adjuvant therapies. Dr. Bhattacharya had proposed as a possible adjunct to lymph node transfer. So we're looking at all pieces. And these lymph nodes, oftentimes lymph nodes, you may say, well, you're taking lymph nodes from one part of the body, aren't you going to cause lymphedema? But it's more complicated than that. Even in medicine, oftentimes we look at the lymph nodes in the axilla or the armpit as a clump of nodes in the armpit, and if you take them out, you'll get lymphedema in the arm. And the lymph nodes in the groin is just a whole clump of nodes in the groin, but it's more sophisticated than that. Some lymph nodes in the groin will drain the lower extremity, some lymph nodes in the groin will drain the abdomen, some will drain the genital region. So if we're taking lymph nodes from the groin, we're aiming for lymph nodes that just drain the abdomen. If we're taking lymph nodes from the chest wall or axilla, we're aiming for lymph nodes that just drain the chest, and I'll show you how we do that. When we first started, or I came back from Taiwan almost 4 years ago, I saw this work. I was very excited, but also skeptical, and we had questions about it. And really, when it's coming down to your own hands, just like everybody in this room who's had lymphedema has their own personal story with it, we have our own personal story and our experience in treating it. And it really came down to doctors, patients, research. But we were asking, is it going to work in our hands here? Is this safe? Are we going to harm anybody? Can we cause lymphedema? And how exactly does this work? So a mechanism, there have been a couple mechanisms proposed. This is proposed by Ming-Wei Chen. He transfers lymph nodes down to the wrist because he feels that that's where gravity pulls fluid. And it does work, transferring down to the wrist. And we've done that, and it works. We now transfer mostly to the axilla for breast cancer-related lymphedema for a couple of reasons, but the bottom line is there's no data which is better. The idea here is that when you sew those blood vessels together, there's a pressure gradient. The artery is pumping blood at a very high pressure. It goes through the lymph node and out the vein at a very low pressure, and that causes like a suction. And the lymph nodes create, they cause lymphatics in that lymphedematous limb to grow into the lymph node. And we know that lymphatics will grow across a scar. This is a study by Dr. Slavin from 1997 showing lymphangiogenesis into free tissue transfer. And this is a sheep model of a lymph node transfer. This is a lymph node that was put in the back of a sheep. This was done by Tabaya, published in 2009. There was no lymphatic connection, but you can see in this lymph node lymphatic connections, lymphatics finding their way into the lymph node. So these lymph nodes, through VEGF-C and other factors, induce growth of lymphatics into them. Somehow they're homing devices for lymphatics, and that's how this really works. We also know histologically there are connections between the lymphatics and the venules, the little veins, so that fluid, once they get into the lymph node, can go out the vein. So our approach to lymph node transfer was first to understand the anatomy. Before we even did this back home, we really we did a lot of anatomic study. And these are lymph nodes. It's going to be without a pointer. Oh, thank you. So these are the lymph nodes. This is an MRA. It's like an MRI, except, and this is really thanks to Dr. Alex Kagan, our radiologist, for these beautiful images. We can see the blood vessels, we can see very detailed anatomy. This is the groin here. These are groin lymph nodes, and these lymph nodes in the upper groin drain the lower abdomen. These lymph nodes down here drain the lower extremity. We looked at these lymph nodes, we plotted at this point over 2,000 lymph nodes. This has been published, this has been presented, it's being submitted for publication. So again, these are lymph nodes down by the vessels to your leg that drain the lower extremity. And these are lymph nodes that drain the lower abdomen, and I'll show you that in real time. So this is all of our data we've looked at, and again, these are lymph nodes up by the groin that drain the abdomen, and these are the ones that drain the lower extremity. So it's not just a clump of nodes, they're separate nodes draining separate parts of the body, and we're aiming for the nodes that drain the abdomen. So we used all this data to come up with a map on our patients, and now we can see in the operating room exactly where the nodes are that we want to take. And this was our first case in preparation. This is a woman who's had breast cancer, stage 3 breast cancers, had an axillary node dissection, chemo, radiotherapy, and lymphedema for 5 years. She was very compliant, and she wrapped 24/7. And I'm going to let her speak. She's given us consent to give her perspective.
What I really didn't like about lymphedema was the constant attention that it needed. I have a busy job where I work many, many hours like most people do, but I found that half my day was consumed by either wrapping and I had 3 major infections, and I think that's kind of when I decided I needed to look for other alternatives.
So our initial considerations taking this first patient was, is this going to work? Have we captured the lymph nodes that we want? Where do we put the lymph nodes, at the wrist, in the axilla? Because we had more experience in the wrist and I saw it work well, and most of her lymphedema was in her forearm, we put them down in the wrist. And of course, what's the risk of this? So our preoperative workup is basically to use every single modality we have available to us. All of our data we collect prospectively. Every single patient we operate on, we really study, and we put them through a lot, because just doing the surgery and not really learning, we're not able to gauge who will really respond to the surgery the best. And that's really the key to any successful surgery. And right now, there are no clear guidelines. So we use the best of what we have to the best of our ability. This includes MRA. It shows that the venous system is open, that there's no evidence of cancer recurrence or disease that may be causing lymphedema. It also gives us a clear lymph volume. So we don't take our own measurements. The radiologist takes our measurements, so our results are not biased. And then, of course, lymphoscintigraphy. We've also been using what's called a SPY. This is indocyanine green is injected into the web spaces, and this is a hand with lymphedema. You can see that it's all trapped in the skin. There is a lymphatic here that's shooting up the arm, and that's a partial obstruction. In some patients, we see that there's a total obstruction. So lymphedema is very different the more we use these imaging modalities. And I have Dr. Alex Kagan to thank for this really beautiful image. This is MR lymphangiography showing the lymphatics within the tissues. And these new imaging modalities let us really understand lymphedema more. So this is a lymph node transfer. This is after removing the skin. At 1 year post-op, her arm is just a different arm. You can see the skin wrinkles. And her pre-op photo, when she was wrapping 24/7, this was the best day she had wrapping. And this is 2 weeks after debulking this. But this is no wrapping, so she ceased doing any form of compression. She just goes with her arm free. Unless she gets on a plane, she'll put a compression sleeve. And this is, again, thanks to Dr. Kagan. We have these amazing images, and we can study these patients after the transfer. So this is a MRA after the lymph node transfer. We can confirm how many lymph nodes we actually transferred. This is all data we collect, how many lymph nodes are successfully transferred and living, in this case 5. And you can see this is a blood vessel that's grown into the lymph node flap. It's just amazing what your body does. It restructures itself. So this shows that we inject, what you're going to see is we injected this patient's hand into the web spaces between her fingers, and you'll see a lymphatic vessel go into the actual lymph node tissue that we transferred, confirming that actually lymphatics found their way into the tissue. So this is the lymphatic here, and it found its way into the tissue itself. And this is 15 minutes after, and you can see these are the lymph nodes, and this is the lymphatic. The only way it got there was from the fingers. We injected in between the fingers, and it found its way right into the lymph nodes. So we can see that this actually does what it's supposed to do. So this is her
And I
post.
probably rap 3 times a week. And I do that because I travel. And that's really the primary reason that my arm swells at all. For example, since last Thursday when I was here, I've flown 4 times. So, and you can see my arm today, it looks pretty good. And I have actually have a wrist bone, which I really didn't realize I had one for a long time.
Well, that's very important.
And I also have an elbow. I didn't realize I had one of those either on my right arm.
But she was really an incredible person, and we followed her. We followed her for a year before we really did anything else, and we were encouraged, but still concerned about the risk, still concerned about donor site morbidity that we cause lymphedema, and also having the skin on the wrist was aversive to some patients. So regarding the donor site, does lymph node transfer cause lymphedema? Is there a risk? And the answer is absolutely there's a risk. Every surgery there's a risk. And the question is not if there's a risk, but what is the risk? Up until recently, there were absolutely no reports of donor site lymphedema in the literature at all. We had not observed any, but just recently, this last month, in the European Journal of Vascular Surgery, there was a report of donor site lymphedema in the extremities after a lymph node transfer, which really underscores the importance of approaching this procedure or any surgical procedure thoughtfully and carefully, and not just taking nodes and transferring them, but really studying which nodes are draining what. And I'll discuss more of that. This led to what we are calling reverse lymphatic mapping, which is really a modification of Dr. Suzanne Klimberg's work. Dr. Klimberg is really to be credited with increasing the awareness of lymphedema in the breast cancer community. She's a breast surgeon and is approaching sentinel lymph node biopsy and axillary lymph node dissection by injecting the arm with a methylene blue with one kind of dye and injecting the breast with a radioisotope, a different kind of tracer. So when she does a sentinel lymph node biopsy, she avoids the blue nodes, unless, of course, they're a sentinel node. But those blue nodes are presumably draining the upper extremity. Or even if you do an axillary dissection, the question is, do you really need to sample any of the lymph nodes that drain the upper extremity? I mean, after all, they're not draining the breast. Are they really going to help in staging breast cancer in your final treatment? And so she has really done a lot of work in this area, and we thought this is a perfect opportunity to apply this approach to lymph node transfer, because the question we're asking is, we don't want to harvest any lymph nodes draining the upper arm. We don't want to harvest lymph nodes draining the lower extremity, and so I'll show you how we're doing that. Why we take lymph nodes from the groin, why we would even consider that, is because we've had a lot of experience with breast reconstruction. Some of these, this tissue that we take from the lower abdomen often crosses these lymph nodes in the groin. There's never been a published report of lymphedema after a breast reconstruction pre-flap that I'm aware of. And so it's territory that we're familiar with, but need to be more familiar with. This is our second patient, and this was our first reverse lymphatic mapping patient. She had a radical mastectomy in 1982. She had supraclavicular, she was radiated in her neck, her axilla, her chest, and she had a Halsted type radical mastectomy, which is when they remove all of the muscle down to the ribs for breast cancer, and had lymphedema for 25 years. Interestingly, never had an infection. Could not raise her arm above her head, was extremely scarred down, a very technically challenging case, a lot of pain, a lot of limited range of motion, a lot of depression. And the reverse lymphatic mapping was really, we were injecting methylene blue, and we're injecting into the arm, and we inject a different color dye into the chest. This is called indocyanine green. So basically, this is the dye that we inject into the chest here. And using the SPY system, we can see a lymphatic. This is a lymphatic here. And these are the lymph nodes. And over here, it's maybe difficult to see, but we can mark the lymph nodes in surgery. And this is what we see in the operating room. But we can mark the lymph nodes. It's like picking apples. Once you make your incision, the dye gets taken up by the lymph nodes. You can see very clearly. And those lymph nodes are draining the chest wall because that's what we injected. You can see these lymph nodes in our tissue that we're harvesting. And then we inject the dye in the vein, in the patient's vein, to make sure the lymph nodes actually light up and have a good blood supply, which they do. And this is 4 months after surgery. You see some reasonable improvement in her limb. And then 6 months post-op, it went from a really just thick, tight, there was no pitting edema here, to a soft, decompressed limb. And it really changed her quality of life. And she was able to raise her arm above her head. This is also thanks to Dr. Alex Kagan. We get limb volume measurements, so we can quantify all this data. We see the dermis, the skin thin, the soft tissues thinner, and we can see the fat. We can see the fat content and water content in the actual limb based on MR. So this is our new technique of reverse lymphatic mapping. Everybody now gets a technetium injection in their foot or in their hand, and then we inject SPY. So for example, this is a patient who's going to have lymph nodes taken from the chest wall and transferred to the lower extremity for primary lymphedema. So where do you get these lymph nodes? There's no book to tell you where to cut. So I'll inject indocyanine green into the chest wall. The patient had technetium, which is a radioisotope used in sentinel lymph node biopsy all the time, injected into his hand. And here's where we can see the lymph nodes. So I'm marking right now the lymphatics that you'll see on the SPY. Here were injections. And on the SPY, you can see these lymphatics draining into the lymph nodes on the chest. So this gives us a very precise map of where the lymph nodes are draining the chest. Now, and these are the lymph nodes that we took. And this, you're going to hear a Geiger counter, and you're going to hear a lot of, you'll hear a lot of noise. The noise is that injection that we injected into the hand. That's all of that dye that was in the hand that's draining the arm that we don't want to take. So I'm putting up this Geiger counter up to the lymph nodes that we are taking, and hopefully there's no noise there because that would be coming from the hand injection. We left the lymph nodes up. You can see we left the lymph nodes up in the patient where they're supposed to be. Those lymph nodes that light up are draining the arm. These lymph nodes didn't take any, there's no sound, so they're not draining the upper extremity. And then we can see on the screen that this tissue's actually got blood flow. We just injected into the vein, and you can see blood flow coming into these lymph nodes. So we confirm that we've got the right lymph nodes, and we also confirm that they have a good blood supply. And we do the same thing if we're taking lymph nodes from the indocyanine vein from the lower extremity in 4 spots, intradermal. So we want to take lymph nodes draining the lower abdomen, not the lower extremity. And again, we can map the lymph nodes using the SPY. Sees it in this side. And then we can make sure we're not harvesting lymph nodes.
The left space is all.
She had an injection
Why
with
not?
the technician. And our tracer. So our tracer line that's draining the lower right here. Can you see the whole leg? That's great. So this really, and then we can know exactly where the lymph nodes we want to avoid and the lymph nodes that we want to take. And that's reverse lymphatic mapping. And so we can see the lymph nodes are in our tissue. This was the injection in the abdomen, draining the tissue. And this is basically what we do. We cut these blood vessels, we sew them to blood vessels in the armpit, and we close up. The patients with this technique is usually home after the first postoperative day. Doppler and at an audible I don't want to get into too much technical detail, but it's important to understand we're really looking at a precise method. Challenges for lymphedema are really measuring outcomes. It is a bit of a moving target, but we do have precise lymph volume measurements pre and post-op based on the MR data. We do pre and post-op lymphoscintigraphy, pre and post-op MR, the SPY, and now we're looking at getting in pre and post-op impedance measurements. This is a comparison of a normal foot and an abnormal foot. We inject the web spaces with the dye, and using the SPY, you see all the dye is not getting out of this foot. It's just stuck in the skin. Over here, this is a normal foot. You can see this beautiful lymphatic sort of filigree just climbing up the leg. So what are the indications for vascularized lymph node transfer? We've treated mild to severe lymphedema, patients that don't have a big arm, but they're wrapping all the time, or they're susceptible to infections, or if it's interrupted their quality of life. And then we treated patients, as you saw, a second patient that had long-standing lymphedema. A lot of the common sort of logic would be treated earlier, it's better, but that's not necessarily what we observe. And I think we have to look at what we do with a very scientific, indifferent eye and report what we see and come to a logical conclusion. We don't want to treat anybody who's got clear signs of venous insufficiency. If there's purplish mottling of the skin and their swelling is clearly from a venous component, that may be a relative contraindication, although it's not clear. What are the risks of lymph node transfer? A seroma is a risk. A seroma is a fluid collection. If you're having lymph nodes taken from the groin, because it's in an active area, you could get a fluid collection. It is a nuisance. You drain it, but it does go away. It's not a serious problem, but it's a pain. Lymphedema, we always discuss with every patient. There is a potential risk for lymphedema at the donor site or at the extremity, and that just underscores the whole reason why we're using this technique that we've presented. There's no published prospective data on this critical issue, and that's also why we're collecting all of this data. So this whole approach is our thinking about lymph node transfer. The recovery is usually overnight for a transfer to the axilla, and about 3 to 5 days for the lower extremity, although it can be longer if you have a skin paddle, it can be longer. Physiotherapy and lymph node transfer go hand in hand, so preoperatively every patient must see an experienced therapist and get their limb down. The whole reason why is we want a good environment for lymphatics to find their way to these transferred lymph nodes to improve our surgical results. And we also ask that they comply for at least 6 months post-op. So this is just something that's that's important. Just as hand surgeon would never send a patient without hand therapy because it doesn't work out too well. In conclusion, finding the best solution to lymphedema really requires a lot of basic science research and understanding lymphedema itself. There's so many questions we still have, and we should rethink the lymphedema staging and classification system. We have new imaging technology. We really should be looking at the different types of lymphedema and observing and seeing which patients are best suited for this surgery. Adjuvant therapies following lymph node transfer, medical therapies following lymph node transfer are something we're looking at and collaborating with our colleagues. We need to do prospective data collection across the board and collaboration and interdisciplinary collaboration. You know, the answer to this problem may be medicine and physical therapy and surgery when indicated. And really having an open mind to innovation. Surgery for lymphedema 20 years ago is not what it is now. Surgery for cardiac surgery 20 years ago isn't what it is now. So every year there are new technologies and new techniques, and we're very open to collaborating with our colleagues. It's one of the things that excites us the most. And the reason why we're doing it is because we see more patients than not have a significant benefit from this procedure. We want to refine our indications and understand this field better. So I'm gonna, these were our first two patients, our first two lymph node transfers underwent first two lymph node transfers in Israel. And Dr. Yoav Barnea, along with Dr. Gore and Dr. Zaretsky, who were gracious enough to have us. This really is an international collaboration. A lot of this pioneering research has been done outside of this country just as well as inside. And so I wanted to thank the Lymphatic Research Foundation, I mean, I can't say enough good things to the founder and all of the people that have helped me be here, Phyllis, Colleen, and Bill. And I'd like to invite Cynthia Schechter, who is a lymphedema therapist and is treated. We've had a common patient, and she's going to also, Lorianne's going to share you her experience. So, Cynthia.
Hi. So my name is Cynthia Schechter. I'm an occupational therapist, and I've been focusing on breast cancer rehab and lymphedema therapy for about 10 years now. I'm here to discuss a patient, Lorianne, who I've known since back in 2011. She was initially diagnosed with breast cancer in February 2009, underwent neoadjuvant chemotherapy She underwent neoadjuvant chemotherapy June through August of 2009, and then had a left mastectomy with expander replacement in August of 2009. She completed her radiation therapy in January of 2010, and some of her hobbies are gardening, woodworking, and spending time with her young grandson, whom she often lifts. Lorianne and I first started working together when she had a sudden onset of swelling in her left hand and predominantly her forearm. Most of the focus of her swelling was below the elbow. At the time of diagnosis, she had moderate fibrosis at the ulnar ridge, which is just from the elbow down the ulna, and moderate pitting edema to the hand and forearm. She had some pooling in the intercarpal space. Prior to coming to my clinic, she saw another therapist to restore range of motion, strength, and functional use of her upper extremity post-operatively after her reconstruction was completed. And the therapist is actually here. Her name's Amy. As far as how Lorianne did during therapy with me, she did quite well. After months of complete decongestive therapy, she presented with very mild lymphedema, trace pitting at her forearm, and zero fibrosis was present. She was able to maintain her arm using a home pump followed by bandaging at night 3 to 5 times weekly, and she would wear a compression sleeve and glove in the daytime during exercise, woodworking, gardening, and when taking care of her young grandson. Although her lymphedema was managed successfully, she experienced multiple exacerbations of her swelling when she lifted heavy things, scratched herself during gardening, obtained mosquito bites when she was at her country home, and was exposed to areas of increased temperature, particularly in the summertime. She was never able to be free of worry and concern regarding her skin injuries and overdoing it, and was anxious about the possibility of developing an infection and having another exacerbation. So she was always back and forth. In February 2012, she experienced a significant exacerbation at her ulnar ridge and dorsal forearm, just an inch proximal to her wrist crease, after she moved a mattress and repaired a brass bed frame at home. And she was devastated. Although she was able to come in for therapy and use her home management techniques to get things back under control, she began to seriously contemplate having the lymph node transfer surgery, stating, "Why should I have to worry about my arm all the time? And what if, God forbid, it gets worse?" So she started to think about it. Preoperatively, Lori-Ann's lymphedema was very mild. So I'm not showing pictures because you probably wouldn't even see a drastic difference. Although her risk for infection was still very high due to a sluggish lymphatic system. And her risk for exacerbation was prominent given her lifestyle, her hobbies, and things that she would do on a daily basis. She chose to undergo the lymph node transfer surgery April 30th of 2012 with Dr. Diane. Postoperatively, Lori-Ann returned for therapy on May 16th. She demonstrated range of motion limitations, which would be normal with any incision to the axilla, and she had more proximal pooling of fluid. Her distal swelling was significantly better, even just a few weeks after her surgery. She was being treated 1 time a week, postoperatively, for range of motion, soft tissue massage, and manual lymphatic drainage, and I would perform compression bandaging. On July 2nd, she was so excited to come into therapy to tell me that for the very first time in years, she was actually able to put on her wedding band, which is a pretty significant thing for any woman who had to stop wearing their wedding band. On August 7th, she came to therapy and told me that despite the fact that she was gardening and had a severe scratch to her forearm from a rose bush, she didn't have an increase in swelling in her arm in the slightest. And by mid-November, she was no longer performing any self-bandaging. She now comes in for therapy 1 time a week, every 2 to 3 weeks, and her treatment consists of approximately 20 minutes on the vasopneumatic pump with the use of a chip sleeve, followed by manual lymphatic drainage, bandaging, scar mobilization, and compression bandaging and therapeutic exercise. Although when she comes for treatment, I continue to wrap her arm, she no longer wraps on her own and reports a significant decrease in stress associated with her lymphedema. So she's no longer afraid every time she goes out and has some sort of an injury that something's going to happen. She knows that she has the tools that she needs, and the transfer seems to have helped any fluctuations in her swelling. So now Lori-Ann's going to speak to all of you about what her actual experience has been and why she made the decision that she made.
Thanks for reminding me that I'm not supposed to do things.
You're always supposed to do that.
Yeah. I don't always follow doctor's orders real well, especially when they interfere with my lifestyle. The first time I noticed my lymphedema was about a year after I had radiation treatment. It was mild and not very pronounced. Then it became much more difficult to put on and take off my wedding band. Then, impossible. I said something to Dr. Evans and he referred to me to Ms. Schechter. At first I was treated 3 times a week and then it lessened to 2 times a week. I also wrapped myself and used the compression machine at home 2 times a week, 2 to 3 times every week. And when I was wrapped, I kept that wrap on from the time I was wrapped until the following morning, which was usually from morning to morning. So basically we're going at least a 12 to 14 hour stretch. I also wrapped myself and used the compression machine. I had to be careful about lifting things, how much weight I used in the gym, picking up my grandson, working in my wood shop, riding my bicycle, because that exposed me to any kind of bug bites, and that could create the lymphedema to increase. In other words, my whole way of conducting my everyday life was impacted. Every scratch, insect bite, burn, cut. Did I mention that the cancer was on my left side and I'm left-handed? Was a worry and caused a flare-up. I read about the possibility of a lymph node transfer and asked Dr. Sampson on a routine visit if he thought I was a candidate. He referred me to Dr. Diane. Since the operation within months, I can always wear my wedding band. I do not react to a simple cut with my arm and or hand blowing up. I work in my shop without fear of an infection from a cut. I flew to New Orleans in September for my daughter's wedding with only a compression sleeve and without having to wrap. There was no swelling. My hand has wrinkles, which is a good thing. I still go for treatment once every 2 weeks, but do nothing in between. I can go away for 2 weeks or more and not worry about how this will affect my arm or health. I also can go to the gym and do weightlifting and all of the other things. I can pull 37 pounds with my arms in a consistent manner on 24 reps with no problem whatsoever and no repercussions. For those of you who say, why did I not wait until there was more research? I was 68 years old. My heart is healthy. People in my family do not tend to die from cancer, but from heart disease. My chances of surviving this operation, whatever the outcome, was excellent. If nothing happened, I lost nothing, and there was every possibility that my life would be improved. No one could guarantee this would be so 10 years from now, and I get to live my life now with much less impact from this disease and without the fear of infection's impact on me.
Thank you so much, Lorianne and Cynthia. It's really an honor to have you. And actually, I've never met Cynthia in person before today.
Lots of phone calls.
We've a lot of phone calls, but it's really an honor to have you both. And I do want to just put everything into proper context. I'm not promoting lymph node transfer as the surgery to do for lymphedema. I think there's a role for every modality. There's a role for liposuction. There's a role for lymphovenous bypass. There's a role for medical therapies and physiotherapies. And really coming to the solution, we're not looking at one thing. We really are looking at the big picture and trying to fit. This is a complicated puzzle, and it's going to likely require a broader perspective than just looking through your facet of your expertise. And that's what's exciting. That's what's exciting about it. And I'd like to open it up to questions, not only for myself and Dr. Smith, but also Lorianne and Cynthia.
I have some questions from the live stream.
Sure.
First of all, somebody had a comment that it's not just PTs that are treating Ellie, but OTs.
Absolutely.
Also, so shout out to the OTs out there.
I apologize. I meant to say I tried to make it a point saying physiotherapy and not physical therapy, but you're absolutely right. Some of our most outstanding therapists are occupational therapists. I apologize. Thank you, Cynthia.
Wanted to know, can the lymph nodes be donated by someone other than the lymphedema patient?
Only if you have an identical twin or a bone marrow donor who, it's probably almost impossibility who you have your chimera. But other than that, unfortunately, your body would reject the lymph nodes.
Anybody in the audience? Well, I'll continue. Any work with this surgical technique for lateral trunk and chest wall lymphedema?
We do not have experience treating lateral wall and chest trunk and truncal lymphedema with this technique, so I couldn't give you an answer.
Has the surgery been performed on a child?
It has. We have not performed. We've had an opportunity to, but we felt in our experience at this point we wanted to collect as much data, long-term data as possible on the adult population, but we are considering the pediatric population now that our understanding, our imaging is better and our understanding of the disease is improved. Particularly, at pediatric population is a very important one because they have their whole life ahead of them, and they may suffer more severe consequences than somebody that develops this later in their adult life. So we're very interested in the population.
After we had word this, so basically I've learned there's no such thing as a doctor that knows about lymphedema. So I'm sitting here listening and I'm fascinated by all the pictures and images and everything. Does your group and everybody, the three of you that are here today, would you see someone like me, but maybe I wouldn't choose to do your particular surgery? But it seems like you're more knowledgeable just by looking at the scans that were done. And no one's ever looked at me to say it's blocked here, it's not blocked there, this could happen. Do you just see people as a lymphedema practice, or is this like you would only go to your group if you were strongly considering surgery? Am I making sense? I never know who to go to. I have no doctor.
We really will see anybody, and we want to learn as much as we want to treat. So even if it's something we can't necessarily treat, there's a whole spectrum of disorders within lymphedema and lipedema. There are proliferative fat disorders, MAD lungs. There are all kinds of, there's a whole complex disease process. And I think if we narrow our lens to just patients that we can treat, we're really missing a big picture and an opportunity to understand this better. So, my answer would just be we see anybody. We're not just looking to focus our practice just to operating on you if you show up. We've turned plenty of patients away from surgery. So it's an open door, and you don't have to feel like you need to have surgery. We don't want that. We don't want to operate on anybody. And in fact, it takes a certain kind of patient to go through this. This is not for everybody.
Thank you.
Yes.
Are there any therapeutic considerations given to the donor site postoperatively, or would you just let that region repair on its own?
Could you be more specific in terms of?
Yes. So, would you have therapists, for instance, who manually drainage collaterally at the donor site, or would you just want to let that rest?
I think it's an excellent question. It's something we thought about in the early post-op period. We just wanted to heal, and manipulating the donor site would probably. We really don't want any manipulation directly on the healing tissues. It takes about 4 to 6 weeks for really your body to heal a wound, any kind of wound. And so we haven't observed lymphedema at the donor site. We have seen some swelling, post-op swelling. We've seen mild swelling, but I think it's a great question. I'm open to it. Probably Cynthia could talk more about that.
Sure. I've had patients who have had transfers, other physicians doing transfers who have demonstrated minimal swelling in their lower extremity post-operatively, minimal swelling in the areas where the graft site was, and I did do it was probably 2 months post-operatively at least, did some manual lymphatic drainage to the area just to make sure that things were flowing, and it seemed like everything settled. So I haven't seen a future exacerbation after that.
Yeah, certainly, if we saw something clinically, we would treat it if there was lymphedema.
I think also it is more of an issue in the lower extremity in the donor site. And we do our patients recommend a compression garment for some patients where we can get something to fit appropriately, just to help with decreasing seroma formation, getting things to heal down. But not necessarily physiotherapy in the early post-operative period.
Yeah, I just to follow up on that, the groin donor site for lymph node transfer, once you remove those lymph nodes, you are removing lymph nodes that drain the abdomen, so you will get fluid buildup, and we do leave a drain in the groin, and we do have the patients wear a compression garment to minimize the risk of seroma formation. But that's really where our focus is.
I was wondering if you have any guidelines for therapists about compression on the limb after the surgery, like how much compression and sort of when you start using that. those kind of guidelines.
That's a great question, and I think that's something that we're looking at and looking to collaborate with lymphedema therapists in terms of, because we've seen a variety of results, and even patients will report, I went here, it was pretty good, but I went to this person and it was just it was night and day, or so it's important to look at what's actually being done. And I wish I was certified, but I'm not, and so I'm really not in a position to give the best guidelines for post-op compression, and so we really have a close dialogue with the therapist. I mean, so if somebody's going to, we speak with the therapist. We've had Amy Shapsis is here. She's been in the operating room with us. She actually wrapped a patient and was doing MLD, and we were looking at things on the SPY system to learn. So we're learning from our therapists, and I think it's a joint collaboration. The basic goal is that we want that limb to be as good as you can get it, so that the lymphatics can find their way to the lymph node without being stuck in a waterlogged extremity. Oxygen tension in the tissues is less, healing is less, everything is just impaired in that kind of environment. So we typically will wrap the patient on the table and do a gentle compression. The first 2 weeks we just want everything to heal with gentle compression. After 2 weeks we start to crank it up.
And what's gentle?
That's a good question. Gentle is much less compression than a patient would ever see in I guess a therapist's office. It literally is a very light ACE, just to avoid swelling, typical post-op swelling.
When somebody asks a question, if you could repeat it, I don't think the people on the outside can hear it on the.
Oh, okay. Repeat the question, the last question.
No, just in general as we go forward, just to keep.
Oh, okay. Yes.
I'm treating a lower extremity, a leg. Where's the donor site?
The donor site, it depends, but it's usually in the chest wall near the axilla. There are other potential donor sites that we're looking at. So let me repeat the question. Sorry. In treating a lower extremity lymphedema, where would the donor site be? And typically, we take the donor site from the chest wall near the axilla. There are other donor sites for lymph nodes, and we're exploring them, such as in the neck. But there are other considerations, such as a scar in the neck, and so forth. The upside from that is it's a little less scary in terms of risk for donor site lymphedema, as lymphedema in the head and neck it's not impossible, but it's uncommon. There's also the omentum, which we're exploring, and that's a carpet of fat and lymph nodes on the inside of the abdomen. But our greatest experience has been with lymph nodes in the groin and the axilla and chest wall.
Has no transfer ever been used for somebody who's suffering from lymphedema in the pelvic area?
The question is lymph node transfer been used for someone suffering from lymphedema in the pelvic region? And it has. It has been used for genital and lymphedema in basically the pelvic girdle and lower extremity. We've looked at that. The patients that we've seen, we did not feel were good candidates for one reason or another. But if the appropriate patient came along, we would definitely consider it. I think you had a question.
Yeah. No, I'm from Shanghai. I'm Dr. Li. I just come here from Boston, especially for this excellent presentation. Have you considered one question? Have you considered the flap orientation when you put the flap in the receiving area? For the node flap, even the vascular pedicle is very length, it's very short.
Mm-hmm.
But But the lymph flow, have a designated position. If we put in one position opposite, possibly will have a negative effect in postoperatively. We have performed experimental lymph node transplantation in 1993 with my colleague, and unfortunately we published our article in Chinese, in Chinese Journal of Chinese Plastic Surgical article. You can still check it out in Medline using inguinal lymph node. The different orientation in the receiving area will possibly influence, the post-operative regeneration of lymphatics. This is my first question. I think it's how you have got an excellent result. The second question is that, not only limited experience, even only two or from one center, only several cases, not so large series. Have you considered, for such kind of technical lymph node transplantation to deal with primary lymphedema? We know that primary lymph have a lot of cases, but up to now, no good way to deal with such kind of patients. It's very, very hard to deal with. I have been involved in lymphatic field for more than 20 years. That's why especially coming from Boston to hear listen to your excellent topic.
Well, Dr. Lee, I'd love to take you to dinner and speak to you more about lymph node transfer. But first of all, it's an honor to have you here, and it's always exciting to hear experience from somebody that's had a vast experience in this field. Dr. Lee was asking about the orientation of the lymph node flap. In his experience, he has a large experience of doing lymph node transfers in China, positioning the flap, and I think what you're alluding to is every lymph node has afferent lymphatics that are lymphatic vessels going into it, and then efferent lymphatic vessels that are lymphatic vessels exiting. So it's got an entrance and it's got an exit. And so you probably want to put the entrance towards the side of the limb that has the lymphedema, and you probably want to put the exit, towards the heart. And I think it's a very, very brilliant point. I can tell you that we have not specifically oriented our flaps. There is a natural orientation that actually, it depends if it's upper extremity or lower extremity. So if it's upper extremity, the orientation of the flap largely depends on the pedicle and the location of the lymph nodes. And we want the lymph nodes typically up against the axillary vein and the fat bridging the area of scar that we remove. We remove a lot of scar, especially in radiated axillas. So I honestly don't know the answer to your question, but I'd be very interested to pick your brain. And the second question was regarding primary lymphedema. What is the role of lymph node transfer in primary lymphedema, which is can be very difficult to treat, and has had mixed results with regard to surgery. Dr. Lee pointed out there are many causes of primary lymphedema. So the first lymphoscintigraphy I showed you actually has a case of primary lymphedema where the patient did not have normal number of lymph nodes on the side that had lymphedema. In such a case, we would consider lymph node transfer because there's clearly a deficiency of lymph nodes. When it comes to a patient who has a normal number of lymph nodes but has primary lymphedema, then it becomes more complicated. I think we're out of answers, and we have to look closely. Is it the muscular function of the lymphatics that is not working anymore, and the lymphatic vessels actually can't milk fluid up to the nodes? If they have a normal number of nodes, they have a lack of number of lymphatic vessels themselves, and the diagnosis of this problem becomes critical. And I think there's just no good published data specifically on primary lymphedema, although we are doing it in patients that we do see that have limited lymph nodes, less than normal.
Thank you so much.
Thank you.
One of the questions I had is, will the slides be available to people afterwards? Would you be able to
I'd have to, because the patients have given their consent to be in this presentation, I have to discuss with my colleague. Usually we don't give all our entire presentation out, but I'm happy to. I'm interested to know what people find the most interesting, the most relevant, and I'm happy to put together something out there. I just want to make sure we preserve our patients, that we have consent from our patients, and that we're putting, appropriate and relevant material. But we're happy to do something like that, maybe an abridged.
I have a question about a specific client who I'm working with now who has been diagnosed with lymphedema tarda, has bilateral lower extremity swelling, and new onset of left upper extremity swelling in her hand. Would she be a person who it would make sense to be evaluated for a transfer, or are there too many regions involved and too much risk for her to even consider a surgical procedure?
That's a good question. So let me make sure I understand. She has lymphedema tarda, so a primary lymphedema that occurred in adulthood and in both lower extremities, and now she has new onset lymphedema developing in one upper extremity. I think we would probably shy away from, just on the surface, we'd probably shy away from doing any surgical intervention. However, I would definitely be interested in seeing her and at least imaging her and getting a better understanding of her lymphatic system, because one of the questions is some patients just have primary lymphedema in the left leg and everything else looks normal, and we've actually imaged them and their upper extremities look totally normal. The lymphatic system looks totally normal. One of the questions is there going to be some latent lymphedema that hasn't presented itself in her other upper extremity? It would make me a little nervous to operate, but I wouldn't cancel all hope. There are other areas like the neck and the omentum, but I would really approach that very cautiously.
Do you think that therapeutically it would help me in terms of where to actually direct fluid if she went through the SPY and the scintigraphy and everything?
I think if we did that together, it would be ideal. If we spied her and you can actually perform MLD on her and see the lymph move, where it's moving.
Okay.
What do you think, Dr. Smith?
Yeah, I think it's an excellent thought. The issue obviously is where are there other lymph node basins that we can use, and also the imaging that we're developing with Dr. Kagan, and that's actually been used in France as well, has given us a better understanding of the architecture of the lymphatic system, and I think it would be very interesting to do this imaging to see really what's actually going on at a structural level, both not only the lymph nodes but the lymphatics and the organization centrally. Some people have obstructions in the central lymphatic transport system as well. So I think it would be very, very helpful, or at least enlightening for all of us, and you could see perhaps if there was an impact with the massage.
Okay. Thank you.
Thank you.
Next question, is this technique, for patients with lipolymphedema?
For lipolymphedema, lipoedema, lipedema.
Yeah.
Is this technique for patients with lipedema?
Or is this just studied, I guess, is the question.
Yeah, we have not used it in patients with lipedema, although I am speaking with, I'm actually in contact with some people who are really focused on lipedema, and it is an interesting area. It's something we'd like to explore. I don't think at this point we would offer it, just because I think first of all lipedema has it's not clear. Lipedema can actually have a lymphedema. You can get lipolymphedema, so you can have a lymphedema component. And for those of you who are not familiar, lipedema is classically bilateral lower extremity, so both legs thickened basically with fat from the hips down to the ankles, and the feet are spared. It's typically symmetric and pretty much exclusively in women, to my knowledge, and it is within the spectrum of lipid or fat deposition disorders. However, the fat tissues themselves can compress the lymphatic system, and you can get superimposed lymphedema on top of the lipedema, or lipolymphedema. I'm not aware of lymph node transfer used to treat this, but again, I'd be interested in evaluating and studying anybody. And really, the imaging, and we can't just look at their skin or diagnose them as lipolymphedema any more than we can just diagnose feel a mass in a breast and say it's breast cancer. We really have to image them, examine them, look at them physiologically, and come to a real diagnosis.
Kind of a general question. What is your criteria for the surgery, and how does one go about finding a place to get evaluated? And not everybody who's listening to this, is in the New York area. I guess it's in general. How do they approach looking for?
Right. So it is. There are really a handful of people in the world doing this with good experience. And it can be challenging. Feel free to call, to contact us, and if we know somebody closer to them, I'm happy to refer. We also travel. Dr. Smith and I travel and perform lymph node transfer surgery. We're going to be performing this in Israel next week, and in Tel Aviv, and then the following month in Taiwan. So we may be coming to your. It's something we'll definitely.
Somebody wants to know, can you clarify when you recommend post-op complete decongestant therapy to resume?
So after following surgery,
Yes.
2 weeks. We have them wrapped immediately, but the real decongestant therapy, 2 weeks.
I think we usually hold off directly on the surgical site a little bit, but proximal decompression and massage usually 2 weeks, and by 6 weeks it's pretty much 4 to 6 weeks anything, including the surgical site. But just I think that alludes back to the question earlier. We just don't want to disrupt the wound, at that time. So most of the decompression is done a bit more proximal in terms of manipulation.
So the blood vessels are only maybe a millimeter and a half wide. So if they're compressed by the compression garment, you can actually kill the blood flow to the transferred lymph nodes, and then you lose the lymph nodes. So the ideal situation is to actually have the patient wrapped by a lymphedema therapist at the time of surgery and every day after, but just shy of where we transfer the lymph nodes. And in the lower extremity, we can't wrap directly over that tissue, so we have to wait a couple of weeks.
Yeah, my last question. For specific patient, how many lymph nodes do you think is appropriate for specific patient? 1 or 2 or 3? Have you considered that?
So the question is, how many lymph nodes do we need to transfer to get a good result? And that's why we're scanning everybody post-operatively and collecting the data on how many nodes that were transferred. And we find that we're transferring between 2 to 5 lymph nodes. So, the reason I'm not presenting our data is because I want to present clean long-term data at least 1 year out. And so a lot of our patients haven't had the full year follow-up, all of the scans, and some patients are from out of town and so forth. But that's something we're looking at specifically. So we'll be able to see how many lymph nodes we transferred and what their result was.
I think we're going to wrap it up. I have one more question. Are you following any of the studies for lymphactin?
I am, but I can't really comment. I know there's a lot of interest and a lot of excitement. We're following a lot of the basic science and medical therapies closely, but I just don't have any personal experience with infacting. Thank you so much.
Just want to thank you all for coming this evening. And I think, what I find so exciting about this kind of gathering, usually to hear the kind of expertise that you've heard tonight, it would be in some medical forum or scientific forum. And there's a pure science element of that, which is kind of interesting. However, what's really exciting is being in an environment like this, where the reason for all that is evident, and that's the human element. So when Lorianne gets up there and speaks, and when I hear your questions, it connects the dots as to why is any of this being done. And I think more and more that's what has to happen in the world at large, because it just isn't anywhere near the level of attention that there needs to be regarding this issue. Too much goes quiet. So I'm very delighted that we got to try this out on live stream, and that's what we're going to continue to do. We look forward to you to continue talking about it. Dr. Smith, Dr. Diane, also Cynthia coming here today and giving the scientific aspects of it, the medical aspects. What you're doing is incredible and exciting. And the fact that you shared that with all of us, we are most grateful and most honored, and really please, a round of applause for all these people that presented to us today and allowed this to happen. Thank you.
We would appreciate if you could fill out and give us some feedback, and also if you'd like to be added to our mailing list so that you'll be informed of when we have other programs or webcasts. Thank you.
Please remember, go to our website, lymphaticresearch.org. There's going to be another symposium May 22nd, and then another one in July. So we look forward to being in touch with you then. Thanks very much. Thank you.